Good morning. I'm pretty sure that very few of you will be surprised to hear that most surveys have found refractory GERD to be the most common reason for referral to a GI practice. However, despite the ubiquitous nature of refractory GERD, its clinical management remains quite challenging. There are, of course, many factors contributing to the suboptimal management of refractory GERD, but some of the reasons are one, a relative paucity of high quality clinical trials to help guide management. Two, an incomplete understanding of the mechanisms responsible for symptoms. And three, the vast heterogeneity of the patient population. With these limitations in mind, during the next 30 minutes or so, I'd like to begin with a few words about GERD and GERD management, and then spend the remainder of the time discussing the management of refractory GERD. Now, before looking at GERD, we should take a moment or two to look at a few definitions. Reflux, of course, is the movement of gastric contents from the stomach into the esophagus. However, reflux occurs quite frequently, and not all reflux events are abnormal. There is so-called physiologic reflux that typically occurs following meals. It's typically short-lived, and most importantly, it is asymptomatic. At some point, and in some patients, however, GERD actually produces a problem, and then we're faced with GERD, that is disease due to reflux. There is little agreement about the exact definition of what constitutes GERD, but I do think the Montreal definition is as good as any, and that is that GERD is a condition where reflux of gastric contents causes troublesome symptoms or complications. Looking very briefly at GERD and its management, there are, of course, a wide variety of symptoms attributed to GERD, and these can be, I think, best thought of as dividing them into esophageal and extraesophageal symptoms. So esophageal GERD symptoms can be further subdivided into typical and atypical symptoms. So typical esophageal GERD symptoms would be heartburn or pyrosis and regurgitation, whereas atypical esophageal symptoms might be something like chest pain. In the extraesophageal symptom category, cough, globus, hoarse voice, sore throat, asthma exacerbation, and so forth would be typical examples. It's important to note that despite the wide variety of GERD presentations, the typical approach to managing GERD has always been kind of a one-size-fits-all approach. However, there has been a recent emphasis on a more, quote, personalized approach to treating GERD. And this has been very nicely and detailed and summarized in the reference shown there. So what I'd like to do is very briefly look at one of the algorithms for managing GERD, and this is the algorithm for the most typical esophageal symptoms, that is sort of heartburn or regurgitation. And it turns out that in patients with these symptoms, about 70% of them will actually turn out to have GERD, and this makes this reasonable symptom to begin with empiric therapy. So typically patients with typical GERD symptoms are given a trial of single dose PPI, typically morning dosing, and then they are reassessed in 1 to 2 months. If they have good response to the medication, then these steps can be taken, which basically means to wean the medicine and then to continue with the lowest effective dose. However, if there is limited or no response to the medication, the AGA recommends compliance assessment and then increasing the dose to twice daily, and then giving it another couple of months. If patients then respond, they can go down this pathway for sustained resolution of symptoms. However, if they do not respond, they are now kind of in the refractory GERD bucket. So what exactly is refractory GERD? We just looked at a pathway and how patients might arrive here, but in fact, there is no widely accepted definition of refractory GERD. the probably most common definition is an unsatisfactory response to BID PPIs for either 2 or 3 months. However, it's important to note that some experts consider a lack of complete response to once daily PPIs as refractory GERD. This has caused a fair amount of confusion when looking at clinical trials because different trials use different definitions for entry into the trial. So it makes it difficult to compare trials because they're actually potentially looking at different patient populations. Also, it's important to note that refractory GERD is patient-driven. That is, unsatisfactory is defined by the patient. And this means that when you look at the refractory GERD population, the frequency of symptoms, the severity of symptoms, the timing of symptoms, even the nature of the symptoms all vary quite dramatically. And this leads to the problem of the heterogeneity of the population. So with that very brief overview of GERD and GERD management, I'd like to now spend the rest of the time presenting an approach for managing patients with refractory GERD. I hope this will serve as a useful framework for managing refractory GERD. It is certainly not the only way to approach refractory GERD, but it is one that I find fairly useful in thinking about when meeting with these patients. So in the first phase, the initial approach, first thing, and I think the most important thing, is to assess whether there are any alarm symptoms. So if the patient has either dysphagia or dynaphagia, bleeding, anemia, unexplained weight loss, persistent nausea and vomiting, or the symptoms began at an age greater than 60 years, or there is a strong family history of gastroesophageal malignancy, then really the next step ought to be an upper endoscopy. In the absence of alarm symptoms, the next thing to consider is whether GERD is actually the correct diagnosis. So is the history consistent with GERD as the cause of symptoms? How was the diagnosis of GERD made? Was it simply a clinical diagnosis? Was there pH testing involved? Has there been a previous endoscopy demonstrating erosive esophagitis, maybe a barium study? Keep in mind that there are a lot of conditions that can mimic GERD: achalasia, EOE, infectious esophagitis, esophagitis, and on and on and on. And this is actually very important, as we'll see in a moment. So if there is a suspicion that GERD is not the cause of symptoms, then I think the next step ought to be some more quantitative testing. That is either a 24-hour pH study or a more prolonged wireless Bravo study, and that should be done off meds. If other tests may be indicated as well, depending on your clinical suspicion. So gastric emptying study, cross-sectional imaging, and so forth might be indicated. So this step in the process determining whether GERD is in fact the cause of the symptoms is very important, because the management of refractory GERD assumes that patients have proven GERD. And in fact, some studies have looked at refractory GERD patients referred to a general GI practice and found that the majority of these patients actually did not have GERD as the cause of their symptoms. Next thing to consider is if you feel that GERD is in fact present, is the patient being compliant with PPIs? Turns out that after only a month, almost half of patients are not taking the PPIs as initially directed. And after 6 months, only about a third of patients are taking it as prescribed. There are a lot of different reasons why compliance wanes over time, and these include cost of the medication, the change in symptoms. Patients may respond to the medications and then decide to change the dose. They may have side effects, or may be concerned that they will have side effects, and so alter the dosing on that basis. Sometimes PPIs are just another of a number of medications they take, and so the compliance kind of slips through the cracks. Also, patients often desire to control the disease in a more natural or non-medication way, and so we'll try to reduce the medications they take. If they are taking the medicines as directed, the next question is to say, are they actually taking it correctly? So patients taking PPIs should be instructed to take the PPIs 30 to 60 minutes before meals. We do know that before meal dosing of PPIs provides much better reduction in intragastric acid. And it's important, I think, to note that it's not just patients who think or feel that the timing of PPI administration is not that important. In one survey, 70% of PCPs polled didn't think that the timing of PPIs was that important, and about 20% of gastroenterologists felt the same. Turns out that just simply changing to the proper timing of dosing can improve symptoms in about 10% of patients. Dexilant or dexlansoprazole might be an exception to this because of the way it is formulated as a delayed release compound. Its sensitivity to timing around meals is probably less important. The next thing you can consider is dose escalation, or in fact, PPI change. First option here would be to increase to BID dosing if it's not already been done. We do know that better control of intragastric acid is achieved when BID dosing is done than compared to QD dosing, and about 25% of patients will improve simply by going from single once per day to twice per day. There is, however, no evidence that increasing dose frequency beyond BID is in fact effective in controlling symptoms. Of course, many patients are already on BID dosing by the time they arrive in your office, and so this option may have already been exercised previously. The other thing you can consider, though, is to switch PPIs. Some patients actually experience symptom improvement simply by changing the PPI they are taking. So in one study, this one by Ronnie Fast in 2008, they randomized patients who had failed lansoprazole at 30 milligrams per day to either receive BID dosing of lansoprazole or to take a different PPI, in this case, omeprazole or esomeprazole. And it turned out that the regimens were equally effective at controlling symptoms. So this brings up the sort of notion that although we usually think of PPIs as being pretty much equally effective, there are in fact significant differences in their ability to control intragastric pH. So this is a table from a paper by David Graham in which they looked at the potency of the various PPIs, and by potency they measured or discovered and pulled from the literature the ability to control intragastric pH. And they used omeprazole as the reference point, and then listed drugs from least to most potent in terms of omeprazole equivalent. So you can see at one extreme, pantoprazole, 40 milligrams a day, was the equivalent in terms of intragastric acid suppression of only 9 milligrams of omeprazole, whereas 20 milligrams of rabeprazole was the equivalent of 36 milligrams of omeprazole. So clearly there's a difference in their ability to suppress gastric acid. However, this is a bit different than whether they control symptoms of refractory GERD any better. And there really is very little data to suggest one might be consistently better than another in terms of PPI selection. But nonetheless, it is worth thinking about this, particularly if they're on something like pantoprazole, trying a different PPI. This also brings up the subject of PCABs. So as most of you are probably aware, PCABs are potassium competitive acid blockers. And vonoprazan was the only PCAB available in the US currently. It's been available for a couple of years as part of combination therapy for H. pylori, but late last year was approved by the FDA for the treatment of erosive esophagitis. I've included in the appendix to the presentation a slide of comparing PCABs and PPIs, but just to quickly summarize, compared to PPIs, PCABs have a much more rapid onset and a more prolonged inhibition of the proton pumps. They are therefore just a more potent acid suppressor than PPIs. They also have the advantage that they can be flexibly dosed. The timing is not important because they bind to both active as well as inactive proton pumps. The timing around meals is pretty much irrelevant. The biggest downside is the cost. They're much more expensive, at least in Massachusetts. Most insurance providers require prior authorization to prescribe the drug. There is, however, no clinical evidence regarding the effectiveness in refractory GERD, although they're clearly much more potent at reducing intragastric acid. Option 3 in the dose escalation strategy would be, if the patient is already on a BID PPI, would be to add an H2 blocker at bedtime. The goal here is to reduce nocturnal acid breakthrough, or NAB, and we do know that H2 blockers are significantly effective at reducing NAB when they're taken at bedtime. The problem, the great limitation, is many patients will rapidly develop tolerance to the medication, and in some studies it can occur as quickly as 1 week after initiating therapy. You can partially work around this by dosing it PRN or intermittently, but it is something worth trying. Although it's pretty clear that H2 blockers are effective at reducing NAB, the effect on nocturnal GERD symptoms has been a bit more variable, but nonetheless, I do think it's worth a shot. Lastly, lifestyle modifications. So the effectiveness of lifestyle modifications in patients with refractory GERD is really quite poorly studied, and the conclusions that are available are inconsistent. Nonetheless, there is some evidence to suggest some lifestyle modifications are effective in run-of-the-mill GERD, and so it's worth recommending these if the patients have not already implemented them on their own. And these include avoiding known triggers such as specific foods, large meals, alcohol with meals, and so forth. Weight loss, although admittedly easier said than done, is effective at improving GERD symptoms. And we do know that elevating the head of the bed and avoiding late night meals will reduce nocturnal GERD symptoms. Also, sleeping in the left lateral position has been shown to improve nocturnal GERD symptoms. So moving now from the first phase of simple fixes or initial evaluation to the second phase, which is diagnostic testing. The first test is an upper endoscopy. Ideally, patients should stop their PPIs for almost a month prior to the endoscopy. And the reason for this is that when patients are on PPIs, the diagnosis of EOE and erosive esophagitis can be masked by the PPIs, therefore missing that diagnosis. Also, in the absence of alarm symptoms, upper endoscopy tends to be a fairly low-yield proposition, with the majority of upper endoscopies being normal. That is, patients will have NERD, non-erosive reflux disease. Nonetheless, upper endoscopy is valuable because it can rule out EOE, which occurs in probably around 5% of patients with refractory GERD, depending on the population. It also rules out things like infectious esophagitis, and more importantly, a malignancy, and other conditions such as pill esophagitis. Another couple of comments about the upper endoscopy in this setting. One is that the presence of long segment Barrett's or advanced LA grade BCD esophagitis is considered de facto evidence that the patient has GERD. Grade A esophagitis, on the other hand, can be seen in healthy volunteers not infrequently, and so is not considered to be diagnostic of GERD. Following upper endoscopy, if that's normal, which it usually is, the next test would be a combination esophageal motility 24-hour pH and PEDIS testing. So, as a sole diagnostic test, manometry is usually fairly limited in the setting of refractory GERD, although one study looking at pretty selective group of patients suggested that 25% of patients with refractory GERD actually had a motility disorder. This is certainly not, in my experience, where I would guess probably 5% of patients turn out to have a primary motility disorder. It is nonetheless important to rule out achalasia and other motility disorders. And furthermore, the motility study is required for the accurate positioning of the pH impedance probe. So the pH impedance probe is really the heart of the matter of this testing. And it's certainly preferred over pH testing solely, where pH testing will be normal in the vast majority of situations and therefore provide little information. This impedance testing should be performed on medications, and the primary goal of the study is to classify patients as having either functional heartburn, reflux hypersensitivity, or residual acid reflux. So the way this is done is that following the impedance pH testing, patients will have either normal acid exposure or abnormal acid exposure. If the acid exposure is normal, they can then be further subdivided into having either a negative or positive symptom association probability. So if the patient's symptoms and reflux events are not correlated, then they are said to have functional heartburn. On the other hand, if they have normal acid exposure, but their reflux symptoms are correlated with reflux events, then they are said to have reflux hypersensitivity. If the acid exposure is abnormal, they have residual acid reflux. And these are the percentage of times that these diagnoses are made typically. So functional heartburn is by far the most common entity in refractory GERD, followed by reflux hypersensitivity and residual acid reflux. So now I want to turn to the specific management of these specific types of refractory GERD. So first, turning to functional heartburn. So these are patients with normal total esophageal acid exposure while on PPIs, but poor symptom reflux association. And once again, this is the most common cause of refractory GERD. The mechanism of functional heartburn is pretty much not understood. Early studies had suggested that enhanced sensitivity was a potential cause of functional heartburn, but this has, I think, pretty much been debunked by the widespread use of impedance testing, which does not support this notion. So I think we're really left with, we have no idea of the mechanism of symptoms in patients with functional heartburn. The population is likely very heterogeneous. So the treatment options, one would be to wean the PPIs as tolerated or as able, and then two, to consider visceral pain modulators. So these, of course, are thought to act at the CNS and or sensory afferent level and used at sub-mood altering doses. There is data, it's scant, but data do exist on the effectiveness of a variety of agents considered, including tricyclics, trazodone, SSRIs, and siRNAs. These have all been shown to provide some degree of relief in limited studies. Now, it's beyond the scope of this presentation to go into neuromodulation, and this is just a table about some studies of neuromodulators in esophageal disorders, and I think it's a good guide to potential dosing for this condition. Another thing to consider is psychological evaluation. It is known that patients with functional heartburn tend to have higher levels of anxiety compared to other groups of patients with refractory GERD. And there has been success with cognitive behavioral therapy, diaphragmatic breathing, and hypnotherapy. So a referral for these is not unreasonable at all. Turning now to reflux hypersensitivity. Once again, these patients have also overall normal acid exposure, but positive symptom association with reflux events. So this is analogous to visceral hyperalgesia seen in IBS and functional dyspepsia. However, as was the case with functional heartburn, the mechanism of symptom production is unknown. There was some thinking that esophageal distension due to increased refluxate volume might be playing a role, but the evidence that the volumes of refluxate are greater in these patients is lacking, making this seem a bit unlikely. These patients do appear to have some sort of hypersensitivity, though, since they do respond to reflux events, even though it's not acidic. First treatment option then, of course, is to try a visceral pain modulator, as in the situation with functional heartburn. There is also similarly fairly scant evidence, but nonetheless some evidence that a variety of neuromodulators can provide relief in some patients. Another option is to try to reduce the number of reflux events by reducing transient lower esophageal sphincter relaxations. As a reminder, TLESRs are those esophageal relaxation or sphincter relaxations that are not associated with swallowing or esophageal peristalsis. Typically, the duration of a TLESR is greater than a swallow-induced LESR, and many of the TLESRs will produce reflux events, although not all. So it's probably the number of the TLESRs associated with reflux is probably the key number. So baclofen, which is a gamma aminobutyric acid B or GABA B agonist, is known to reduce TLESRs by a significant amount, about 50%. The main limitation here is that it crosses the blood-brain barrier, which gives it a propensity to produce CNS side effects, particularly in older patients. And so somnolence, confusion, tremors can be a limiting factor. Nonetheless, a trial is reasonable and many patients will actually respond. So starting at a low dose and then titrating up as tolerated is a reasonable approach. Treatment option 3 is to consider an anti-reflux procedure, and this is pretty controversial, but studies have suggested that surgery can benefit a significant number of patients with reflux hypersensitivity. The best known study is probably the one by Stu Speckler, published in the New England Journal in 2019. And in this study, patients with reflux hypersensitivity or residual acid reflux, which we'll come to in a moment, were randomized to either lapnicin or active medical therapy, which in their case was omeprazole 20 milligrams BID, followed by baclofen titrated up to as much as 20 milligrams TID, followed by a trial of dizipramine, or placebo medical therapy, where patients received omeprazole BID, but placebo baclofen and placebo dizipramine. Although the study was fairly small when all was said and done, it did provide some interesting results to consider. So they defined success as a greater than 50% improvement in the GERD HRQL score at 12 months. And using that definition of success, they found that surgery was significantly superior to active medical treatment and also superior to medical placebo. Turned out that active medical and medical placebo were not significantly different, although numerically patients seem to respond a little bit better to medical than placebo. So they concluded that a lapnicin is better than medical therapy at 12 months, and that active medical therapy and medical placebo were not statistically different. Do note, however, that the nisin response rate was 67%, which is considerably lower than the 90 to 95% success rate in patients who are having nisin for kind of routine GERD that responds to medications. And you would be sending people to surgery with only about a 67% chance of success. This has suggested to others that other anti-reflux procedures might be worth considering. So LINX and endoscopic anti-reflux therapy and even Roux-en-Y gastric bypass have all been done in small numbers of patients, although there are no large trials to suggest its effectiveness in refractory GERD and particularly reflux hypersensitivity. Turning lastly to residual acid reflux. So these are patients with abnormal esophageal acid exposure despite taking high-dose PPI therapy. So why might patients have incomplete acid suppression? Well, one is metabolism. It's known that PPIs are metabolized via the hepatic cytochrome system, which varies depending on your specific genetic makeup, and the result can be either quicker or slower metabolism of the drug. The bioavailability is also known to vary, although not by huge amounts. And there is a rare known mutation in the proton pump gene that can confer drug resistance. And of course, patients could, on rare occasions, have Zollinger and Ellison syndrome. And so checking their fasting gastrin level does make sense. So what can you do for treatment? One is to additionally escalate the medication. So one is simply increase the PPI dose. I have patients taking as much as 80 milligrams of omeprazole BID to suppress their acid, and it does seem to work. You could also consider adding H2 blockers or alginate-containing antacids. And this actually might be a role for PCABs down the road. That's really quite intriguing. I think time will tell. Treatment option 2 would be to use neuromodulators, or treatment 3 would be to try to use TLASRs with baclofen much, as is done in reflux hypersensitivity. And lastly would be to consider anti-reflux surgery, as we discussed previously, or anti-reflux procedures such as LINX or TIF and so forth. So finally, I wanted to just give this summary table, which I use personally as a reference. So based on the 3 categories across the top there, functional heartburn, reflux hypersensitivity, and residual acid reflux, I've checked here the options available to you in these situations. And so it really will boil down to fiddling with these and hopefully coming up with something that can adequately provide relief to these patients. Lastly, before I conclude, I've included a couple of slides in the presentation, but I won't go through. It talks about PCABs and also some other treatment options that have been considered, such as sucralfate, bile acid sequestrants, and so forth. And with that, I will stop. Thank you very much.